welcome to our presentation about opioids. So the opioids are one of the agents that is commonly used as a preanesthetic agent, and it is mainly indicated for its analgesic property. Actually, opioids are derivatives of opium. So we also have here a closely related term, the opiates. So when we say opiates, these are the natural opioids. So they are naturally derived. Um, Examples of this are heroin, morphine, and codeine. When we are going to compare that with opioids, so opioids refer to all natural, semi-synthetic, and synthetic opioids. So for the effects of the opioids, they produce analgesia and sedation. They are indicated for anesthetic induction. So they can be used for anesthetic induction when combined with other drugs. And can also be classified as agonist, partial agonist, agonist antagonist, or antagonist. So basically, the antagonist or the reversal agents of the opioids are of course used to reverse the effects of the opioid drugs. These are the classifications of the opioid drugs as well as the commonly used opioid drugs in veterinary medicine. So again, we classify opioids as either agonist, partial agonist, agonist antagonist, and purely no antagonist. For the agonist, the commonly used ones are the ones in red. So we have morphine, hydromorphone, and fentanyl. For the partial agonist, of course, we have the buprenorphine. For the agonist antagonist, we have the butorphanol as the commonly used agonist antagonist. And for the antagonist or the reversal agent of the opioids, we have the naloxone. So again, the opioids are great because we can reverse their pharmacological effects, and again, we can use naloxone for this purpose. So every opioid is controlled with the exception of the antagonist, naloxone, and nalbuphine. They are administered via different routes: IV, IMSC, oral, rectal, transdermal, subarachnoid, and epidural. So in this case, in the picture we have here the fentanyl. So fentanyl is usually administered via transdermal patch in the skin. They have a wide margin of safety, so if used properly, especially in animals, the animals don't get addicted to this drug. Opioids now mimic the endogenous opioid peptide. So the endogenous opioid peptides that are produced in the body are the endorphins, dynorphins, and the enkephalins. So these are the ones that are being mimicked by the opioid drugs. So the opioids produce analgesia and the sedative effects. So this is a result of the action of the opioids on the receptors. So these receptors now are found in the brain and the spinal cord. So there are different types of receptors, opioid receptors. So we actually have five, and the most common are the mu, the kappa, and the delta. But of course, the most clinically significant that we are going to focus are the mu and the kappa receptors. So these are the most clinically relevant, and in this case, it is important that you know which drugs act on which receptors, because it determines how they are going to act in the body or what kind of effects they have in the body. So each opioid receptor has a different action at each receptor. For the MOA of the opioids, so the opioids interact with the opioid receptors that are found in the brain and the spinal cord. So the opioid, when it will be able to bind to these receptors, of course, it will induce its effects. We also have the buprenorphine, a specific type of opioid. It is a partial mu agonist. So it does not, of course, produce a 100% effect on the mu receptor. So take note that the mu receptor is the one that mediates or causes a significant analgesia. It still has a good analgesic effect, the buprenorphine, but not as comparable to that of the other full opioid, full mu agonist. It also happens to antagonize the kappa receptor. So the buprenorphine is a partial agonist to the mu receptor and an agonist to the kappa receptor. So in terms of the kappa, so of course the kappa receptor is responsible for some analgesia and sedation. We also have the naltrexone. Naltrexone is a mu antagonist. It is, of course, an antagonist drug, no, and it is going to block, no, the effects of the, of course, the mu receptor. Are the different opioid drugs, their classifications, and their indications. So we have those opioid drugs that are full agonists, and of course they will bind to and stimulate the mu and kappa receptors. They are indicated for moderate and severe pain. So again, examples of this are pure agonists, no morphine, hydromorphone, fentanyl, and others. We also have those that are partial agonists, and they bind to and partially stimulate the receptors. Example is buprenorphine. We also have the agonist antagonists. They will bind to, for example, a certain opioid receptor, and they will antagonize or they will block the other opioid receptor. Examples of this is butorphanol. For the antagonist, of course, it will bind to and don't stimulate either the mu and the kappa receptor. Examples of this is the um, naloxone. So this diagram shows the different opioid drugs and their MOA, and their properties, on these different receptors. So we are only going to focus more on the mu and the kappa receptor. So in the case of morphine, meperidine, fentanyl, and these drugs, so they are full agonists, because they will have, an agonist property to the mu and the kappa receptor. In the case of butorphanol, so it is a mixed agonist antagonist. Butorphanol is a partial agonist to the kappa receptor and an antagonist to the mu receptor. For the naloxone, naltrexone, and nalmefene, these are the examples of our reversal agent or opioid antagonist or full antagonist. The pharmacological effects of the opioids, starting with the CNS. For the CNS, there is a dose-dependent effects on the CNS, particularly in dogs, for example, it can cause sedation and narcosis. In the case of cats, horses, and ruminants, they get CNS stimulation. So they get a bizarre behavior patterns, and they also have dysphoria for these species. So these species are considered to be more prone to the bizarre behaviors induced by the opioids. For lower doses, the drug can induce analgesia in these species. So of course, it is important to note that the analgesia. So for the pure agonist on the mu receptors are considered to be the most effective for a severe pain, and we use this most of the time as pre-meds for painful surgeries. Of course, the function of the mu receptor, its physiological role is mainly on analgesia. So it has a potent analgesic property. When you are going to stimulate that receptor, it will induce a potent analgesia. So any surgery we expect to be painful will have a pure mu agonist as part of that pre-anesthetic protocol. So of course, examples of this are fentanyl, or oxymorphone, and the morphine. These are pure mu agonists. Um, we also have of course, the pure agonists are most effective against severe pain. No, these are the pure mu agonists. They can also be used as a pre-med for painful surgery. So, for the case of butorphanol, no, butorphanol is a mixed agonist antagonist. It actually blocks the mu receptor, but it has a partial agonist effect on the kappa receptor. So again, the disadvantage of butorphanol is that it blocks the mu receptor, and again, the mu receptor is responsible for the most effective, the most potent analgesia. So that is why butorphanol is not a good choice as an analgesic, for moderate to severe pain. For the cardiovascular system, opioids can cause bradycardia. For the respiratory system, there is a decrease in the respiratory rate and tidal volume. So when you say tidal volume, that is how much the air that the animal moves in and out in one breath. So opioids cause a shallower breathing, a decrease in the rate of breathing. So there is, of course, no respiratory depression. So these are the other effects of opioids on different animals. So for dogs, it can cause meiosis, while for cats, horses, and ruminants, it can cause mydriasis. So opioids have a varying effect on the body temperature of the patient depending on the species. So this is exemplified by hydromorphone. So hydromorphone is the most commonly used pure mu agonist, and it causes hypothermia in dogs. And for cats, now as you can observe in cats, there is the development of hyperthermia. So temperature must be regularly monitored, well monitored for cats because again cats now have a tendency to develop this condition which can be detrimental to the health of the patient. Another property of the opioids is that it can cause increased responsiveness to noise. So when the the cats are on opioids or the animals are on opioids, so they have this increased sensitivity to noise. There is also a sweating in horses and decreased urine production with urine retention. Are the adverse effects of opioids? So for the CNS, the opioids can induce no anxiety, disorientation, excitement, and dysphoria. Of course, the when we say dysphoria, no, that is the unpleasant hallucinogenic effects of these opioids. Um, we also have the cardiovascular effects on the cardiovascular system. So again, it can produce pronounced bradycardia. For the respiratory system, there is also a decreased respiration and tidal volume. We also have a decrease in the partial pressure of oxygen and carbon dioxide. So for this parameter, we have to particularly monitor the blood gases for patients having under anesthesia with opioids. There is also a it is dose dependent with some agents, and there is also a ceiling effects with some agents. So when we say ceiling effect, so once you get to a certain dose of the opioid, it doesn't get any worse. Ceiling effect of this respiratory depression. For this adverse effect, so for example, when there is dysphoria, severe excitement, and disorientation, so you can reverse this. You can use a reversal agent, and we have naloxone as a reversal agent for um, some of these adverse effects of opioids. So these are some of the adverse effects of opioids on the GIT. So it has a significant effect on the GIT because it can cause salivation and vomiting, particularly in small animals. This is especially true with the pure mu agonist, hydromorphone, oxymorphone, and morphine, but less so with fentanyl because fentanyl is usually administered via concentrate infusion. We also have diarrhea, vomiting, and flatulence. So we can pre-treat the animal with atropine to prevent this hypersalivation and diarrhea. And we also have aspromycin, no, an antiemetic for vomiting. So there is also GI stasis following initial GI stimulation. So this is one of the disadvantage of using this atropine because it can exacerbate the condition, which is the GI stasis. For horses, it may predispose the animal to developing colic, and this should be, of course, the opioids should be avoided. Avoid administration to any animal with a GI obstruction. Other effects of opioids, it can cause addiction or physical dependence in humans. There is also facial swelling and hypotension, increased IOP, and intracranial pressure. The opioids are used as preanesthetic agents, so the choice now of whether we are going to use a pure agonist, partial agonist, a mixed agonist antagonist, of course, will depend upon the procedure and how long it is going to take, the procedure. The opioids can also be used alone or in combination with tranquilizers. We also have the anticholinergics or alpha-2 agonist. For the opioids are of course indicated for analgesia. So this drug will prevent and treat post-operative pain, and they can be used with tranquilizer to produce neuroleptanalgesia. Is neuroleptanalgesia. So when we say neuroleptanalgesia, this is a profound state of sedation and analgesia induced by simultaneous administration of an opioid and a tranquilizer. So we have here the list of our opioids that we can combine with our tranquilizers in order to produce neuroleptanalgesia. So um, our most common combination to produce neuroleptanalgesia is, for example, our dexmedetomidine or medetomidine and hydromorphone. So we can combine them in order to produce neuroleptanalgesia. Of course, these are dexmedetomidine. No, these are alpha 2 agonists. And again, we can combine them with our opioid in order to produce neuroleptanalgesia. So when do we use neuroleptanalgesics? So we use neuroleptanalgesics for to produce sedation for minor procedures. So if we don't want a general anesthesia, we can use neuroleptanalgesia. We can also use local anesthetic with this. They can also be used for induction of general anesthesia, particularly in dogs, and but we don't, of course, use them in young healthy dogs as well as in cats. To our individual opioid drugs. So we have here morphine. Morphine is it is the prototypical mu opioid agonist and is a safe and effective analgesic for most small animal patients. It is efficacious for mild to severe pain and has the added benefit of being a good sedative for dogs. When we are going to compare that with other commonly used mu opioid agonists, morphine has a longer duration of action and less expensive. For the side effects of morphine, particularly in dogs, these are generally dose and route administration dependent, and this includes respiratory depression, bradycardia, vomiting, defecation, dysphoria. We also have the histamine-related vasodilation and hypotension. The oxymorphone and hydromorphone. So these are equally effective analgesics, but they have a shorter duration of action compared to that of morphine. They are also associated with a lower incidence of GIT side effects and do not cause histamine release following IV administration. So that is the advantage of oxymorphone and hydromorphone compared to that of morphine. We also have buprenorphine. So buprenorphine is a unique drug in that it is classified as a partial mu agonist. So unlike the aforementioned drugs that have a high potential for human abuse and are therefore federally restricted, buprenorphine has a fewer government restrictions, particularly in the US. So its efficacy as an analgesic for small animal patients continues to be studied with promising results following both IV and buccal mucosa administration in cats. We also have our butorphanol. So butorphanol is an agonist to the kappa receptor and a mu antagonist drug. It is less effective than morphine or oxymorphone for moderate to severe pain and has a short to intermediate duration of action. While its efficacy as a sedative seems to vary, it is thought to cause less respiratory depression and dysphoria compared to the other mu opioid agonist. So the use of opioids for induction of anesthesia is reserved primarily for dogs due to the potential for significant arousal in cats with high-dose IV administration. Fentanyl, oxymorphone, and hydromorphone are or the opioids that do not release histamine when administered IV are best suited for use as induction agents. So naloxone is considered to be a pure opiate antagonist and it has no analgesic activity. So the exact MOA is not understood, but it is believed that the drug acts as a competitive antagonist by binding to the mu, kappa, and the sigma receptors. So the drug apparently has its site affinity for the mu receptor. The naloxone reverses the majority of the effects associated with high-dose opiate administration. So, for example, we have the respiratory and the CNS depression. In dogs, naloxone apparently does not reverse the effects, emetic actions of apomorphine. So it takes about 5 minutes for the reversal, IM. And if you give that by IV, slowly IV, it is about 2 minutes now for the reversal. If your original opioid agonist is going to last longer than 30 to 60 minutes, then those animals might become sedated again and might have some of these effects coming back. So these are the reversal agents. Now for our opioids, we have the opioid antagonists. So they are mainly indicated to reverse the undesirable effects of the opioid drugs, including the respiratory depression and the CNS depression. So the patient wakes up now after being sedated. We also have under this, now we have the naloxone. Of course, naloxone can be given IM or slow IV in dogs, horse, cats, and exotic animals. And it is usually used in clinics, and most of the time it can be used as an emergency drug. We also have the naltrexone. So naltrexone is another opioid antagonist. It is used more in wild animals, and it has a longer effect, and compared to that of the naloxone. Effects of the opioid antagonists, again, they are reversal agents, so they will reverse the effects of the opioid agonist, partial agonist, and the agonist antagonist. Of course, this includes now the CNS depression as well as the cardiovascular depression. Um, a reversal can be complete in a few minutes, and these are the adverse effects, but these are considered to be rare. There is sudden analgesia, now because sudden analgesia loss can cause excitement, anxiety, and sympathetic nervous system stimulation. So you are reversing again the effects of your opioid. So opioids are analgesic. So when you are going to reverse that, there could be a sudden analgesia. It can cause excitement, anxiety due to the sympathetic nervous stimulation. So to prevent this, you can use an agonist-antagonist drug, and that one of that is the butorphanol. We use opioid antagonists. So of course, we are using these opioid antagonists or the reversal agents now for in emergency cases when there is an overdose and like when the animals are getting totally dysphoric. And we can, in this case, now we can administer naloxone. We can also use them to reverse neuroleptanalgesia. So for example, if we're using hydromorphone together with our dormitor, our alpha-2 agonist, these are both reversible, so we can reverse them and we can administer naloxone. And it can also be used now to revive neonates delivered by cesarean section. So a lot of times when we do cesarean section, we use of course, the dam receives the opioid. So the neonates that are not going to do very well, we can come out with the opioid in their system, and we can give them naloxone. And of course, this is administered, under or the drug is placed under the tongue.